Yeah, hi, I'm Associate Professor Ian Scott from Princess Alexandra Hospital in Brisbane, Queensland.
Thank you very much for joining us at the end of a very, very long day for you of presentations. Now, could you say what your presentation was about? What study were you doing and what prompted it?
Okay, I guess it wasn't a study as such. It was really just a model, a different approach to trying to reduce low-value care and looking at what actually influences clinician behaviour. So what the basic idea was that we need to talk about the elephant in the room, the thing that actually often influences clinicians to do the things they do, which we think are of low value. And my feeling is that a lot of it is driven by cognitive biases, the things that influence our decision making in relation to our sense of regret if we don't do something that then may result in a poor outcome for the patient, whilst not realising that many patients that we do these things to don't benefit, and in fact in some cases may actually be harmed. Also, I think looking at often the ingrained attitudes and beliefs that we hold from our original medical training and from being socialised amongst peers, we come to believe in the appropriateness of certain things that scientific evidence actually tells us is no longer true, is no longer effective, and therefore we need to disown them and stop doing them. So my presentation was really focused on a sociocognitive approach to try to get people to think and reflect about their own thinking, what drives them to do the things they do, and to see, okay, perhaps I need to understand that what I believed once is no longer valid, and perhaps we should change tack. I presented a process by which we could make people more aware of a low-value care problem that exists in much of medicine, and then to come together in working out, well, what is consensus around low-value care as a group of peers? How can I unlearn some of the things that I've been led to believe over the years? And what then perhaps can I substitute? Because if we're saying to folk, we think that some of the care you're doing is now no longer valid, okay, if I stop doing that, what can I put in its place? So it's not taking something away and leaving us in a void. I feel I will need to do something for my patient. I want to do something for my patient. I want to be seen to be doing something. But we need to look at what can you do that actually is effective rather than something that's really quite wasteful. So I think that angle of substitution is important. And then beyond that, we need to say, right, if people now have been made aware that yes, this is a low value problem, they agree with it, they understand what it's about, yes, they've reflected on their own thinking and they can understand that we need to change. Okay, how do we then make sure that change actually happens? So that brings in strategies around things like nudge strategies, trying to get people to get together as peer groups and discuss things openly and honestly, talk about cognitive huddles where we actually dissect our own decision making and see how we can improve things, what we can do in relation to use of data to actually feedback on a regular basis exactly what our care is doing in relation to patient outcomes, okay, and then move on to recognising that now a new form of care should be the standard and that the old form of care now should be disowned.
And what chances do you have of doing all of that in a busy hospital environment?
I think we need to try to incorporate this at all levels. So this should even be introduced in undergraduate medical courses. In fact, we're working on trying to introduce a module of critical thinking skills in our own undergraduate course to acquaint clinicians that are in training in this psychology of how we think and biases that can affect our thinking simply because we're humans and we're just as fallible as anybody else. So we can make people aware of those biases and then give them strategies to counter them, then we think that may certainly be a benefit, particularly as students in the undergraduate level have yet to develop these ingrained beliefs that may then more likely be prevalent in older folk who continue to think in a certain way. So I think that's important. I think in terms of clinicians who are already working, I think what we need is patient narratives have a powerful effect. So if we can show that care that was well intended but actually resulted in a poor patient outcome, then I think that does tend to grab their attention, and they want to obviously avoid that in the future. So I think patient narratives, feedback of instances where there's been considerable patient harm, or a waste or a constant waste of resources that are quite limited and that we should redirect into better forms of care. I think if we can acquaint clinicians with that sort of data and that sort of feedback, that also will have a significant effect.
And was this part of a Choosing Wisely project actually at the hospital, and is it leading to actual programs of change?
It's not necessarily a Choosing Wisely program as such. It's really an approach that I've developed based on my own experience leading quality and safety improvement in my own department, in my own hospital, and also having led a number of multi-site quality improvement collaboratives. So I think it's really a product of that experience. Has it been formally tested? No, it hasn't. That's where we are at the moment. But I think the fact that it seems to have a fair degree of face validity, and given the positive responses we've had now to presenting it both here at Choosing Wisely and also at Queensland Health, I suspect that perhaps we are now talking about the elephant in the room that everyone perhaps is aware of but doesn't really want to talk about.
And what about for yourself? You're a clinician. Did you struggle with change too? Have you ever struggled in this way? Did you have a breakthrough moment? What is it for you?
I think the breakthrough moment for me is my interest in evidence-based medicine that developed in the mid-1990s, and I realised that a lot of our medical training really had not done us very well. It was rote learning. It was not in any way encouraging us to challenge or to be critical of the dictums and the information that we were given. It was just a matter of imparting knowledge and wisdom to the students in an apprenticeship model. I'm not saying that that's necessarily a bad thing, but we need to teach the next generation to be a little more questioning of so-called standards of care, to challenge why do we do this? What's the evidence that it actually is of benefit to patients? Are we doing the right thing? So I think that more critical attitude is very important to instill into the next generation of clinicians.
And you said that patient stories are powerful. Is it often something that terrible that happens that makes a clinician rethink?
Well, certainly it does. What we want to make sure is that they don't then just reflect on that one instance and think perhaps it was a one-off, or one was just unlucky, or things happen that perhaps were beyond my control and therefore I don't really have any responsibility. Things sometimes happen not only because of individual decision making, but because the system encourages a group of people to think in a similar fashion. So we need to tackle both, but my feeling is that we individual clinicians, we comprise the system. We are the system of care. So if we don't change, then the system is unlikely to change. So responsibility lies with us to, again, reflect critically and see whether perhaps there are things that we need to change.
I'm glad you raised that about systems, because it's not a big part of Choosing Wisely's work. They concentrate very much on working clinician-led responses and consumer ones. We all know outside of that is an entire policy-making and funding system. Fee-for-service is a big thing. Variation of fees from specialists. There are a whole bunch of other things that are driving behaviours that could affect whether people choose wisely.
Yes.
What's your position on those?
Well, I think the system does influence you, there's no doubt. But my feeling is that we tend to overrate the influence on individual decision making of these other system factors. I'm sure they're there, but I think it's the belief systems that really drive most clinicians in doing what they do. Financial incentives, guidelines, performance standards, these are the more traditional approaches. Yes, I'm not saying that they don't have any effect. I'm sure they do, but I don't think that they have as much effect as people think they do.
That's interesting. So where to from now for you?
I think we need to refine the approach further. I think we need to test it in a real world environment. I think we need to survey our clinicians with it and see whether they think this actually is something that they can work on. I think that in the past, when I presented this to our clinician group, they acknowledged that yes, these influences on their decision making do exist, and that yes, we should be more critical and adopt what we call a metacognitive approach. In other words, we think about our own thinking a little more than perhaps what we do. Will that actually make a significant change in behaviour? I think over time it will, and I think that there's nothing to be lost in actually using this approach, because we know that the traditional knowledge translation approaches, such as guidelines and audits and feedback and so forth, they seem to have a limited impact. They have some impact, and we shouldn't not use them, but I think that there are other more potent cognitive factors that we need to look at.
Fantastic. And one last question, a takeaway for you from today? Anything stand out that interested, surprised, worried you?
No, I think people in various quarters are doing some very good work. I think that the strong consumer involvement in today's meeting was good, because at the end of the day, shared decision making, I think, is a significant plank. If patients themselves are challenging and wanting explicit answers to their questions around whether this is needed, whether this is of benefit to them, what's it going to cost them if there's any out-of-pocket costs, that does get practitioners then to have to reflect and justify why they want to do something. And I suspect, and the evidence would suggest, that the more this questioning attitude from consumers is practiced, then the more conservative and more patient-centred the care becomes, and less likely will then care be given that's really of no benefit or potentially harmful.
Fantastic. Thank you very much.
Okay, thank you.